Okay. Good morning, good evening. My name is Dr. Toure Alhassane. I'm physician and epidemiologist. I'm currently working with World Health Organization in the unit of World Health Emergencies. And last 3 years, I'm implementing and coordinating the Ebola ring vaccination in the field in response of Ebola virus disease outbreak in the Democratic Republic of Congo, DRC. So in this presentation, we are going to talk about the Ebola vaccine, and we are going to talk about the context and the targeted community. We're going to talk about some common misinformation about the vaccine and some strategies we use to overcome that misinformation. We also are going to talk about the challenges of this outbreak and our success in this adventure. So we finish with some reflection in the implication for the future vaccine intervention, like COVID-19, for example. So the Ebola vaccine has been introduced as vaccine trial in the Ebola virus disease outbreak science in Guinea, in West Africa in 2015. Then we expanded to the Sierra Leone in 2016 under compassionate use protocol. So the vaccine has been part of the Ebola outbreak response in DRC since 2018. There was multiple vaccine under development, but only 2 of them has been used in the North Kivu outbreak, the 10th ABD outbreak of DRC. The Merck Ebola vaccine, even what not licensed before, has been shown to be safe and effective in helping stop an Ebola outbreak caused by the Zairian strain of the virus in Ebola outbreak area. We use the ring vaccination to stop that outbreak in North Kivu. So it also the only one vaccine who has been recommended by World Health Organization Strategic Advisory Group of Experts in Immunization for Outbreak Control. Later in 2019, an additional vaccine was introduced. It was a Johnson & Johnson vaccine, J&J, who was a 2-dose vaccine. So the second dose to be administered 56 days later. So the Ebola RVSV vaccine is the only vaccine with human clinical efficacy data. It has been used in 10 countries before DRC under phase 3 trial. And during the study in West Africa and Guinea, the study we call Ebola Sasufi, this vaccine showed high efficacy in controlling of the outbreak. So it's a single dose vaccine, and it can provide protection after 10 days. So the vaccinated people, we used to advise them to continue to respect the measure to protect themselves from contracting the disease. The RVS visible vaccine recently in December 2019 was licensed as Evibov by the European Medical Authority and the US Drug and Food Administration. So the licensed dose are still in production. So we are using the investigational dose in the field. So we use this vaccine under a compassionate use protocol, and we use it in the Equatorial Province in DRC from May to July 2018, where we vaccinated more than 4,000 people. And in the North Kivu outbreak from August 2018 to June 2020, we vaccinated more than 300,000 people. And then now we are still fighting in the Equatorial Province in 2020, So far, we already vaccinated more than 41,000 people. So we use this vaccine under informed consent form to be in compliance with good clinical practice, because the vaccine is not, the licensed dose are not yet available. So we use the ring vaccination strategy to implement these activities. So the vaccine are limited doses because we don't have a lot of doses to use it as a mass campaign vaccination. So we have to target the people with at risk. And this vaccine need an ultra cold chain. The vaccine need an ultra cold chain to be used minus 30, minus 80 degrees Celsius. So that may be the case for the COVID-19 vaccine also. So if we can use the ultra cold chain for implement these activities in DRC, in Guinea, and in Sierra Leone, so the other country also can be able to implement that same condition to implement to realize the activities, maybe for COVID-19 vaccine or another vaccine. So in 2018, there were two Ebola outbreak in DRC, as I previously mentioned. So first in the Equator province in northwest area, and second, who was the second largest AVD outbreak globally in the world, who spread in the North Kivu province and spread to South Kivu and Uganda. So most areas with active Ebola transmission were inaccessible to so many partners because of the security concern. And it's an area where we have the presence of armed conflict and almost 40 years history of regional instability, with many urban and densely populated areas. So the social and economic network is doing through the porous border with Rwanda, Uganda, and South Sudan. We also have the presence of the refugees. In this area, there is minimal to no healthcare infrastructure, and the active outbreak are measles, cholera, and malaria. So the community resistance is complex because most of the community does not believe the existence of the Ebola disease. That maybe will happen with COVID-19 also. And the community feel themselves excluded and marginalized by the country leadership. So they mistrust and disbelieve that the government will take any action on their behalf. When we try to go and meet the community and try to take their concern, we had a lot of questions about the vaccine. First, does the vaccine have any adverse effect, especially fatal or sexual? If there are adverse effects, who is going to take care of them? Does the vaccine kill? This concerns the security of the vaccine for them. Does the vaccine make men weak and women infertile or children unintelligent? So they need to be sure that the product is safe for them. Why are certain category of the people in the community and also certain villages in the same province are excluded from the vaccination? This question regards our strategies, because we don't have a lot of doses to make a campaign, a mass campaign vaccination. So we need to target to the people at risk. And community want to understand why this exclusion. So we need to explain them why we are using this protocol, why we are using these strategies. Why not vaccinated door-to-door like we used to do with polio, for example? So the strategy is question again. And are diabetic and people with other chronic diseases allowed to be vaccinated? There's question regarding the eligibility criteria. What are the eligibility criteria for the vaccines? For example, what Are some people offered one vaccine and others another vaccine? That kind of question occurred when we introduced the second vaccine. So people wanted to understand the difference between the two vaccines. Why is there policy presence? Why is there a policy presence? Why do the policy officer accompany the vaccination team? Due to the context of security, we need to protect our staff. So community have to understand why we are using this. It's not against them, it's just for the security of the staff. And they need to understand all the steps of our activities. And why has not the vaccine become mandatory when it was not previously? And this is a big concern of misinformation. So the vaccine was never, it was not a mandatory vaccine. So people need first to consent before they get the vaccine. But the misinformation, the fake news was spreading that the vaccine was mandatory. And it's like we are forcing them to get the vaccine. This was not true. So we need to meet them and fix all this concern. So in our strategies to try to overcome this misinformation, we need to understand that our response activities intersect with communication. So we need to go and meet the targeted population and explain them why we are here. We need to be focused on the affected population. We need to train our vaccinator around effective risk communication. So to be able to address the concern by themselves, need to work with partners with social and behavioral science to collect and evaluate community feedback. We can use community survey, focus groups, and qualitative analysis, and then integrate all this and this feedback into vaccine strategies. Of course, in compliance with good clinical practical, because we are using an investigational products. So we can use all the communication channel we can, radio, TV, and other social media, Facebook, WhatsApp, etc., because we need to address community misinformation. We can provide job aids to vaccinators, so to let them be able or assist them to address community feedback. And we can also help the healthcare workers, local healthcare workers. We can focus on their education and communication to support the promotion of the vaccine. So from all this, we understand that it is imperative to effectively reach and share the right message to the targeted community and include them in the process from the beginning to the end. It's important to work on the capacity building to allow the local community to implement and organize the fee activities by themselves by using the local healthcare workers. We have to regularly review and adapt the implementation strategy based on the fee context and community feedback. So for that, we implement some innovative approach in the concept of ring vaccination by using, for example, targeted geographic vaccination, pop-up vaccination, and we also add a third group of people at risk we call probable contacts. So we understand that everything is around the community. So community is the most important thing, community first. So we need to respect local beliefs, includes local traditions and customs in the communication strategies. We need to respect and consider local authorities. Each village has its chief. His community has a leaders among the women, among the young people. So we need to walk alongside them because we're here to help them. We never don't overlook the different facets of communication and how vaccine rumor may spread, especially through social network. Organize meeting with the affected community and at all levels for all vaccination activities. We have to understand that on my side, I used to say that when you have community acceptance, That means 90% of the work is already done. So in this outbreak, it was one of the most complex and difficult response in the war because of the insecurity, presence of the army group, uncontrolled army group at the all level, all the village. And with the big concern of logistic issue, because the road is not good. We need to move by car, by motorbike. Sometimes we have to use the boat because of the logistic issue. And fighting against virus like this is fighting against the time. So we have to react quickly, and we need to move also quickly, and which was a big concern because of the logistic issue. The roads are not good. So despite all the noises, all the challenges, all these challenges, we were able to implement ring vaccination around more than 90% of Ebola cases. So the goal was achieved, and we were able to vaccinate more than 95% of eligible people. We were also able to follow out more than 90% of the vaccinated people, which was a very big achievement in this context. So in total, we vaccinated more than 300,000 people in Eastern Congo, 60,000 contacts, more than 191,000 contact of contacts, 51,000 probable contacts, more than 60,000 healthcare workers and frontline workers, more than 1,400 pregnant women, more than 5,500 lactating women, more than 2,000 children under 1 year old, and more than 10,000 people from 1 year old to 17 years old. So for the implication for the future activities, for example, as I said, COVID-19 vaccine, it's important for us to work closely with communication and social and behavioral science partners to collect and analyze community feedback. And we have to do this routinely. We need to consider different forms of mass communication and develop a communication plan using messages based on evidence, tested and validated. We need to target the beneficiaries of the vaccine and adapt the communication strategy accordingly. We have to understand that each country is specific and unique. Each community is different and unique. Right now, for the COVID-19 vaccine, it's mandatory for us to anticipate the common rumor of the targeted communities, address them, never ignore them, and develop a strategy that addresses local beliefs and misconceptions. The lesson learned with Ebola vaccine can be useful for establishment guidelines and strategy for other vaccine intervention, including COVID-19. We have to understand that during an epidemic, the vaccine can protect the population at risk against the virus. The vaccine can limit the scale of the outbreak or a pandemic. The communication should be targeted to the affected population with respect and not always focus on the social media, because some of the rumors also was from the international media. All the goal is not doing the communication for the sake of the communication or for the sake of the social science. The goal is to interrupt the transmission of the virus by vaccination. That is the goal. And this is how we achieve this. Here here are the results, and then the lesson learned. So we have to insist that on the need of local one-to-one communication with people than rather general receipts. So being together with an effective vaccine, we can stop